Unit 6. Intrauterine growth restriction. Importance. The prenatal identification of intrauterine growth restriction, IUGR, is important because it allows timely delivery of the fetus with chronic hypoxia, who is at risk of intrauterine death. Early identification of serious fetal abnormalities and fetal infection. The neonate is at risk of preterm delivery, birth asphyxia, hypoglycemia because of poor reserves of glycogen and other energy sources, for example fat, polycythemia from intrauterine hypoxia, hypothermia, increased mortality, especially if also preterm. During childhood, most show catch-up growth, but some remain short and thin. There is a slight increase in risk of learning difficulties with IUGR, depending upon underlying etiology and gestation at birth. Definition. IUGR is the failure of a fetus to achieve his or her genetic growth potential. Most will also be small for gestational age, SGA, although the two terms are not synonymous. SGA means that the infant is below a particular weight centile for gestation. The 10th centile is most often chosen, but the 3rd or other centiles are also used, figure 6.1. The higher the centile chosen, the higher the proportion of infants included who are normal but small. The lower the centile used, the higher the proportion with a pathologic cause. The fetus may have growth failure but may not be SGA as their weight is still above the 10th centile. For this reason, a prenatal combination of ultrasound features are utilized to identify IUGR in the fetus. A. Estimated fetal weight or fetal abdominal circumference less than 10th centile for gestation, i.e. SGA. B. A reduced fetal growth velocity, change in abdominal circumference less than 1 standard deviation over 14 days. C. The presence of oligohydramnios. D. Abnormal cerebroplacental ratio, of middle cerebral artery to umbilical artery pulsatility index, or absent, or reversed end diastolic velocity on Doppler ensonation. The presence of 2 or more of these conditions places the fetus at high risk from IUGR. Figure 6.1 chart showing increase in birth weight with gestational age. Most small for gestational age fetuses or infants are constitutionally small. Etiology. Maternal. Undernutrition, for example, famine in developing countries, eating disorders. Maternal hypoxia, for example, cyanotic heart disease, chronic respiratory disease, high altitude. Drugs, for example, cigarettes, figure 6.2, alcohol, illicit drug use. Placental. Reduced maternal uterine vascular supply, preeclampsia, chronic maternal disease, for example, hypertension, diabetes mellitus, renal disease. Placental vascular thrombosis and or infarction, for example, maternal lupus anticoagulant, antiphospholipid syndrome, sickle cell disease. Unequal sharing of uteroplacental vascularity, multiple gestation. Fetal. Chromosomal disorders, for example, trisomy 18 and other syndromes. Structural malformations. Congenital infection, CMV, toxoplasmosis, rubella. Figure 6.2. Reduction of birth weight with maternal smoking. Pathophysiology. Traditionally, IUGR has been classified as symmetric or asymmetric, though in clinical practice, there is considerable overlap and this distinction is no longer important prenatally. Symmetric, growth failure affecting weight, head and length. Caused by fetal factors, for example, chromosomal disorders, syndromes or congenital infection. May be accompanied by polyhydramnios, if there is reduced fetal swallowing of amniotic fluid, for example, trisomy 21, Down syndrome, or gastrointestinal obstruction. The infant is likely to continue to be small throughout childhood. Asymmetric, growth failure with head, reflecting brain, growth relatively preserved. Classically caused by uteroplacental insufficiency with reduced oxygen transfer to the fetus. Fetal adaptation to hypoxia is to preserve blood supply to the vital organs, that is, the brain, myocardium and adrenal glands, at the expense of the kidney, gastrointestinal tract and liver, limbs and subcutaneous tissues. This is reflected in maintained head growth but reduced abdominal circumference from reduced glycogen stores in the liver, and oligohydramnios from reduced urine production. If it progresses, it results in fetal acidemia and fetal death. Management. Management is intensive fetal surveillance to maximize gestation without compromising the fetus, Figure 6.3. Figure 6.3. Consequences of progressive uteroplacental failure with increasing base excess and worsening fetal blood pH, acidemia, which may result in intrauterine death. Progression may not follow sequentially. Reduced growth velocity on biometry. Decompensation of middle cerebral artery Doppler velocity, with loss of preferential cerebral blood flow redistribution. Abnormal ductus venosus Doppler waveform denoting diastolic cardiac dysfunction. Reduced fetal movements. Abnormal fetal heart rate tracing, decelerative and then terminal. Poor renal perfusion, fetal urine production and reduced liquor volume. Abnormal umbilical artery Doppler waveform due to increased placental impedance, absent and then reversed end diastolic flow. Reduced fetal breathing movements and fetal tone on ultrasound. Intrauterine death or hypoxic damage to fetus. Establish if there is a fetal cause by detailed ultrasound scanning for fetal anomalies and karyotype if indicated. Monitor fetal growth and well-being from measurements of growth parameters, biophysical profile, amniotic fluid volume, fetal movement, fetal tone, fetal breathing movements, fetal heart activity, and Doppler blood flow velocity, umbilical, ductus venosus and middle cerebral artery. Timing of delivery will depend on gestational age, if growth ceases or there is an abnormal biophysical profile, or significant abnormality of the Doppler flow velocity waveform, Figure 6.4 and 6.5. Postnatal. After birth, monitor for hypoglycemia and polycythemia and examine for dysmorphic features or congenital infection. Figure 6.4. Umbilical artery Doppler waveforms and diagrammatic representation. Normal, A and B. Absent end diastolic velocity, C and D. Reversed end diastolic velocity, E and F. Doppler signals from the umbilical artery give information about fetoplacental blood velocities. Increased blood flow velocities in the fetal middle cerebral artery and absent or reversed flow in diastole in the fetal aorta indicate fetal hypoxia. Figure 6.5. Doppler flow velocity waveform of the ductus venosus showing A. Normal, and B. Reversed flow during atrial contraction. In the second trimester growth-restricted fetus, this represents cardiac decompensation. It is a better predictor of stillbirth than umbilical artery Doppler alone.